So I'm going to be speaking about cervical cancer. These are my disclosures. And our learning objectives are going to be starting with a discussion of management of early stage disease, moving into then the locally advanced setting, and then talking a little bit more about specifics about brachytherapy target concepts and OAR doses, and then some updates in systemic therapy for metastatic disease. So starting off with the incidence, in the United States, cervical cancer is a relatively uncommon disease. It doesn't even make the top 10 kind of female cancers in the US. There are about 14,000, but this is a big problem globally with about 600,000 new cases per year. The other good news for us, in the United States, and hopefully for the rest of the world will catch up to us, is that the HPV vaccine you can see on the right was introduced in 2006. And we are seeing that in younger women in their 20s, a decrease in the incidence of cervical cancer by 33% from 2005 to 12 and 65% between 2012 and 2019. So I'm encouraged that we are seeing this. But for now, there are still a number of women that still need our help. And the question is, how can we best do that? So in terms of the distribution of the stages that women are presenting in, you can see on the left that, the highest percentage of women fortunately present with localized disease, but there's a good number, about a third, that present with regional disease and about 15% with distant disease. In terms of their overall survival, as you would imagine, it's highest for localized disease in the 90% range, but then starts to drop into kind of the 50-60% range for regional, and unfortunately even worse for distant patients. The real thing, though, to look at is all the way on the far right. We can see that if we look over time, over the past few decades, that unfortunately the overall 5-year overall survival is unchanged, just letting us know that we still, again, have some work to do to improve outcomes for these women. In terms of updates in staging, there are some kind of major changes between the 2009 and 2018 kind of FIGO staging. There's a comparison here kind of in this table that's presented. The biggest changes are that you can use imaging such as MRI and PET. 1A tumors now only defined by depth of disease. The 1B group is now split into 3 sizes. And now there's a distinction between pelvic lymph node positive and periaortic lymph node positive patients. In terms of staging, MRI is really best for assessing the local extent of disease. You can see that it's highly specific. In the EMBRACE study, they saw a 25% difference between the MRI stage and their clinical exam-based stage. And you can see over on the left here some examples of T2-weighted MRs. Some of them include vaginal gel, looking at kind of different stages, and it's a really very helpful tool. The other imaging modalities seem to have about a similar sensitivity and specificity for detecting nodal disease, but most often I think PET-CT is used to evaluate regional and distant disease, again with a much higher specificity compared to sensitivity. So if we move on to kind of treatment options, we're going to start with the early stage disease. Surgery is usually most often done for early stage patients. And if you look at the NCCN guidelines here, the one thing that I want to kind of point out that we'll discuss a little bit is that as you move kind of from like a early stage 1A2 to 1B1 down to kind of the bottom of this page, you can see that the type of surgery that's being recommended is a little bit different, ranging from extrafascial in the earliest stages down to radical hysterectomy. We're going to talk about that a little bit, but you can also see that for like the 1A1 to 1A2s with LVI and then the group below, that radiation can also be considered. So look, we're going to talk about how you kind of discuss that in tumor board. So in terms of types of hysterectomies, there are different classification schemes. This is one of the more commonly kind of used classification schemes. And as we go from kind of the left to the right, start with an extrafascial hysterectomy. If we just think about how much of the parametria is being removed and how much of the vagina, there are other differences as well, but just focused on those two. you can see that with an extrafascial hysterectomy, there is no parametrial resection and minimal vaginal margin. For modified radical hysterectomy, there's about a 1 to 2 cm, like kind of horizontal resection in the parametrial space, kind of at the level of the ureters, and a little bit more vaginal margin. And then a radical hysterectomy kind of goes out even more laterally into the parametria with a resection at the medial aspect of the internal iliac vessels and takes more of the vaginal margin. Okay, so this is helpful to know in terms of what type of surgery is your surgeon doing. Other updates in surgery kind of include on the left the LAC trial, which randomized patients to either open surgery or minimally invasive surgery, showing an overall survival advantage with the open approach, and that remains a standard of care today. There is an increasing role of sentinel lymph node biopsies in cervical cancer, currently best used for tumors under 2 centimeters. And the SHAPE trial is supposed to be reporting out soon in the next year or two, which is, again, trying to see if you can do less surgery for a low-risk population. In that table there, I have the criteria for a low-risk patient to see if you can just do an extrafascial hysterectomy compared to a radical hysterectomy. And so it's good that women will have hopefully kind of less kind of extensive options, hopefully in the future for their surgery. In terms of discussing, like in the early stage, do you do surgery? Do you do radiation? There's a little bit of literature here to guide us. One is the Landoni trial that randomized early stage patients either to surgery or radiation. The group that got surgery had adjuvant radiation therapy in about 64% of the patients. With 20-year follow-up, the overall survival is the same, and the disease-free survival is the same. They did see some differences in complications, though. So the patients that got surgery plus radiation had more toxicities compared to if they only did surgery or they only did radiation. The other thing is, if we look on the right, you start to see that not all patients are the same. So as you see for squamous cell patients, as the size of the cervical tumor got larger, there was kind of a widening of differences in overall survival in favor of radiation as the tumors got larger. And at the bottom, you can see that the outcomes for adeno patients are different, and they're not quite the same. And all this kind of shows is that, it's difficult to say that all patients should get surgery or all should get radiation. And there are some things that need to be individualized. In terms of radiation, with kind of the most modern techniques that we have, which we'll spend more time kind of discussing with image-guided adaptive brachytherapy. This is the Retro Embrace series, kind of in early stage patients, showing that we have very high local control at 5 years, 98%. High overall survival, 83%, and relatively low kind of grade 3 or higher morbidities, kind of under 10%, suggesting that this is also an appropriate treatment option. So how do you put together whether you should do surgery or radiation in these early stage patients? I think there are a number of things that can be discussed. This was nicely discussed in a recent summary in Pro. You need to think about the patient factors. Is this someone that can come in for radiation? Are they elderly or frail? Maybe radiation is better than surgery. Think about the side effect profile. Is this a young woman that you're going to put into premature ovarian failure? What about vaginal stenosis or GI side effects or late-term complications with radiation in younger women, whereas surgery has a little bit more GU side effects? And then think about the procedural risks of surgery versus brachytherapy. And then also we have the ability now with PET and MR to evaluate kind of intermediate and high risk features at the time of diagnosis, both with MRI and PET. And if those are present, we know that doing surgery and radiation can carry more complications. And so maybe those patients would be better just going straight to definitive radiation. So let's transition into talking about some of those intermediate and high-risk features in the post-operative setting. So these are women who've gone on to surgery, and the question is, should they get any more treatment? We usually divide these into either intermediate risk patients, also called SEDLIS criteria, or high-risk patients called Peters criteria. And so let's talk about the two trials that help guide us in this space. The first is the SEDLIS trial. These were kind of 1B cervical cancer patients treated with surgery, and they had to have some combination here in this table of LVSI, stromal invasion, or tumor size. And if they met those, they were randomized to observation or radiation therapy. The majority of these patients were squamous cell, and you can see on the right that there was an improvement in PFS, but not overall survival. And this is why patients who meet these criteria, we suggest this consideration of radiation therapy. Okay. For the Peters trial, this is kind of the higher risk population, patients, again, with early stage disease treated with surgery, and you could get into the trial with either positive margin, positive parameter, or positive pelvic nodes, and patients were randomized to radiation only or radiation plus chemotherapy. Again, the majority of these patients were squamous cell, and on the right, you can see that there was a significant improvement in both PFS and OS for this population. And again, this recurring theme of seeing some worse outcomes for the adeno group. There has been some realization that maybe our criteria that we're using are basically kind of too limited, and that maybe we can be more nuanced. Most of these trials were designed to estimate about a 30% risk of recurrence. But what we've realized is that the risk of recurrence for squamous cell and adenos are different. This is an ancillary study of multiple GOG studies trying to see if the risk factors for predicting recurrence are different between squams and adenos. And it looks like that they are. And so if you look on the far right, if you take a patient with LVSI, superficial third invasion, and tumor size over 5 centimeters, that for a squamous cell patient, the estimated risk of recurrence at 3 years is about 20%, but closer to 45% for an adeno. So how do we kind of move forward with that? There's kind of what I think of as like an updated SEDLIS trial that's ongoing called the Cervantes trial, which is basically trying to use kind of modern imaging with tumor size as opposed to using the clinical size, which was what was done on SEDLIS, and introducing some newer factors like tumor-free distance and kind of redoing SEDLIS to see, is there a group that can be observed versus a group that should continue getting radiation in this setting. There's also different studies looking at patient selection for chemo. For patients with intermediate risk factors, is there a group that benefits from chemo? Again, SEDLIS did not include it. And then there's a group here on the far right thinking about higher risk patients that maybe they need even more than just the chemo RT during the radiation, and maybe they'll benefit from additional cycles afterwards. We will see what these results show. In terms of how do you treat these patients, if you're going to treat, we have 2 randomized trials comparing 3D versus IMRT, the TIME-C trial and the PARSER trial. The TIME-C trial, basically the endpoint was a patient-reported outcome using the EPIC questionnaire, which many of you may use in your prostate patients. And they found an improvement in terms of a reduction of bowel toxicities at 5 weeks compared with baseline in the IMRT arm. And the PARSER trial looked at physician-reported outcomes, again, seeing a reduction in late GI effects in favor of IMRT. There was recently an update of the TIME-C trial. You can look on the left here at the EPIC bowel scores. Again, at week 5 of RT, you can see the significance of the primary endpoint. But at 1 and 3 years, the curves kind of overlap. In the top right, if you look at pro-CT-CAE scores, you can see significant differences in the amount of antidiarrheals that are being used by patients and the frequency of diarrhea at 1 year, but at 3 years, those kind of go away. And in the bottom, you can look at the EPIC urinary scores. You can see that at 3 years with longer follow-up, that there's an improvement in some of the EPIC urinary scores in favor of IMRT. Okay. In terms of the patterns of failure, again, this is the first really big study looking at IMRT versus 3D and using smaller fields. It looks like what we're doing for our fields is okay. We've got about a 4% versus 2% local regional failure risk, which is not significantly different, suggesting that our volumes are reasonable that we're using in the IMRT setting. When you're doing kind of IMRT, there is an energy post-op contouring atlas. Here, first author is Bill Small. I won't go through the specifics of this, but this is a very helpful tool to have kind of when you are contouring. Okay. And in the NCCN, they do now have some recommended dose constraints for IMRT that you can use here that are pretty much kind of adopted from the TIME-C trial. In terms of, is there a role for brachy boost in the postoperative setting? This was a question addressed in the ASTRO cervix guidelines for Sothers Ginzocchino. KQ4 was asking this question, and it's conditionally recommended in the presence of a positive margin, but the strength of the evidence is low. You can see on the right side, most of the benefit that's been suggested of doing it, it comes from things like NCDB studies. We don't have randomized data. In terms of the dose, there's kind of a range of what people do, but I put some values or some suggestions that are in NCCN or the TIME-C trial that are reasonable if you are going to be doing it. So let's transition to the locally advanced setting. In the locally advanced setting, kind of external beam plus chemo plus brachytherapy is the standard of care. This is a category 1 recommendation. Before we talk more about that, I'm going to just kind of diverge a little bit just to talk about this line here for patients who get imaging and have positive adenopathy on imaging, just to discuss this scenario for a second. So for patients who have imaging done, let's say a PET CT, and have a positive pelvic node, but the periaortic nodes are negative, if you look at NCCN, there is a suggestion that maybe some of these patients should have surgical staging of the periaortic nodes. Just wanted to have one slide on this so that if you're sitting in tumor board and you're wondering, like, why are they recommending that? Just to give you an understanding of that. So the situation is, if you have a positive pelvic lymph node on imaging, but negative on periaortic imaging, there's data to suggest that the rate of actual positive periaortic lymph nodes might be on the order of about 20%. And so the GYN oncologists feel like, hey, we should tell you that, because that's 1 out of 5 patients that could impact what you do. There's definitely some controversy about that. This question is being asked on an open trial, the Parola trial, which hasn't reported out yet. But hopefully this information can help you understand at least where your GYN oncologists are coming from if they are suggesting it. Okay. Let's get back to the general chemo RT paradigm. It includes about 5 weeks of external beam radiation given with concurrent weekly cisplatin chemotherapy. For 5 to 6 cycles. I drew this as doing all of the brachytherapy at the end, but it can be kind of interdigitated starting, during the external beam, and all treatment should really be completed within 7 to 8 weeks. Where does our evidence come to do chemo RT versus RT? We have a number of trials, and there was an NCI alert that in 1999 that demonstrated a survival advantage. This is a meta-analysis kind of showing an improvement in overall survival with the addition of chemo to radiation. So this remains our standard of care. One of those essential trials, just so that we have it as background, was RTOG 9001 that randomized women to either extended field radiation or to chemo RT. This was to point A, so not image-guided adaptive brachytherapy. And you can kind of see the range of outcomes here, which is good to have as a baseline. As we talk later about some of the EMBRACE data, the one thing I'll point out is the local regional failure of 10 to 30%. And we're going to see that we've made big strides in that. And we'll talk about that some more. So where have we made the biggest improvements in improving outcomes for these women? It really has been moving from a 2-dimensional to 3-dimensional brachytherapy. Traditionally, we dose to point A. The problem with point A is that you can't really see the tumor on 2D imaging, and you can only see parts of the OARs. But if you move either to CT and kind of even better with MR, you can see that you can see the target, you can see your OARs, so you can make sure that you're covering it well and make sure that you're reducing your dose to your OARs. In order to move to volume-based kind of brachytherapy, you have to have a common language for how what volume you're going to dose to. This has been put forward by the ASTRO. They originally presented these concepts in 2005. The most relevant one to us is going to be the high-risk CTV, which includes the GTV plus the entire cervix plus gray zones. and then also this concept of an intermediate risk CTV, which can include kind of an asymmetric expansion outside of the HRCTV that's supposed to include sites of the initial disease involvement. These concepts are easiest to see on MR, but some of us don't always get to use MR, and there are some contouring guidelines based on CT. I put a reference down there in the left kind of corner. So what data do we have to support these concepts? There's a series of studies that have been done now called the EMBRACE kind of studies. It initially started as a retrospective collection of data in RetroEMBRACE, and EMBRACE 1 has been published. EMBRACE 2 has been completed, should be published soon, and EMBRACE 3 is now in development. So let's take a little bit of time to talk about these studies. Oops. So the RetroEMBRACE, again, this was initially retrospectively collecting data using these image-guided concepts for the brachytherapy. And what we see is that they found initially that there's a dose response to the HRCTV. The larger the HRCTV, the higher the dose that you need to get to kind of maintain the same level of high local control. And again, confirming the importance of the overall treatment time. In the middle here, we saw that for larger HRCTVs, that if you added kind of interstitial needles using a hybrid applicator, that you could increase the dose to these targets, and that led to an improvement in local control, but it did not lead to increased toxicities, which was really important, and we'll talk more about that. And ultimately, what they found kind of on the far right was that as you got the doses higher and you covered the disease, that you changed the patterns of failure. So the local regional failures went way down, and you started to see a higher risk of distant metastases. So this was a change in the patterns of failure from what we were used to seeing. So that was all retrospective. Could we prove the same thing in a prospective manner? EMBRACE 1 was over 1,000 patients. About 40% of them were treated with hybrid applicators with an overall treatment time closer to about 7 weeks. And what we can see on the far right is that, the local control across all stages was, greater than about 90% for all groups, which is really amazing. This is really a big advancement and a big improvement, but, we are still seeing about 30% kind of failures when we look at the 5-year disease-free survival. What else do we learn about patterns of failure in EMBRACE 1? Well, we look at kind of the group of patients starting here in the beginning that went on to chemo, RT, and brachytherapy. At 3 months, 81 patients had persistent disease. Of those 81 patients that just went observation, 60 patients had local control, so they converted, and 21 patients progressed. So in total, they had only 7% with a local failure. That includes 77 who had initial complete response, but then developed a local failure, and that 90% of the local failures were in field. So it's important that this shows that this target concept works, that the target itself, that people are failing in field, and that we probably don't need to make anything larger. Most of the failures that occurred happened to be kind of in the mid to distal vagina. But this is relatively uncommon, and there isn't a thought that the HRCTV concept should be kind of modified, okay? The other thing is important to look at what's the natural history of a local failure. So half occurred within a year, almost all within 2 years. The 5-year overall survival is about 25% with a local failure, but no patient with persistent disease survived. So this is really important because you need to do the best that you can the first time around to get maximal local control. The other thing was there was no difference in 5-year tumor control overall survival if the patient developed a complete response at 3 months versus it took 6 to 9 months. And about half the patients with local failure presented with synchronous nodal or systemic disease. There's also a paper published this past year looking at multivariate analysis for risk factors associated with local failure. So again, we see this common theme of histology being important, with failures higher in the adenodes versus the squames, the D90 being important, the maximal tumor dimension, HRCTV volume, time, and a few other things. If you look on the far right, though, just to give you a sense of the difference in outcomes between squames and adenodes, this is a graph that just looks at the HRCTVs over 40 cc's, and you can look like in the red is the adeno group, the blue is the squame group. So for D90 of 85 gray, 95% 3-year local control of squame, but only 86% if an adeno or adenosquame. So again, seeing some differences in biology and response here. Toxicities from this treatment. This is an update from Embrace 1, looking at patients with grade 3 or higher CTCAE version 3 toxicity. So this is physician assessed. What you can see here is that if you look at the sum of GI, GU, vaginal, or fistula, that it's almost 20%. It's a little higher maybe than we would like to see. And if you add kind of those toxicities plus kind of non-GI, GU, vaginal, with the most common being fatigue or insomnia, that rate is almost like 25%. So while we've made a lot of strides here, it is important to realize that we are seeing some, grade 3 or higher late toxicities, and we need to think about how are we going to kind of improve on those. The other thing is not all grade 3 toxicities are created the same. And what I mean by that is this graph looks at women who had a greater than or equal to grade 3 toxicities that had at least 3 follow-up assessments after their grade 3 event to see like, well, what happened? Sometimes we make the assumption that these grade 3 toxicities are permanent and never go away. And that's not true. And so kind of what happens is the numbers here represent the number of patients, but let's look at just GI bleeding, for example, is that the majority of cases, this can be managed and the green represents resolves. But let's look at a different toxicity like urinary incontinence. You can see a much different picture in terms of kind of what happens. And so it's important to continue following these patients. And for some of these symptoms that don't completely resolve, it's important to be there for the patients to help them kind of manage and to try to kind of deal with some of these long-term changes that can occur. So let's kind of move on to like, how do you actually do this? What are you going to do? We'll start with the external beam. So the external beam, talk a little bit about IMRT, targets, kind of dose, talk a little bit about nodes, which I think is pretty confusing in terms of the dose, do it, SIB, sequential. You do have to think about the dose that you are contributing to your brachytherapy during your boost and the dose that the brachytherapy is contributing to your nodes, and then prophylactic PA nodal coverage. And then just one comment on a parametrial boost. It's not done on Embrace. It's unclear if it's still necessary in the area of image-guided adaptive brachytherapy. We don't do it anymore in our practice. But I do think that there definitely, if you do it, it is pretty complex in the era of like not always using just like a pear-shaped distribution and kind of how you block out certain areas and then add dose to the parametra. But I would say in our practice, we're not really using it anymore. So IMRT helps with a lot of things, including PA coverage, SIB, keeping OARs down, but you've got to think a lot about motion. So in terms of kind of how to contour, there are some contouring guidelines from Dr. Lim here. There are different ways of thinking about the CTVs. This is how I do it. Doesn't mean that this is how you have to do it. But usually we'll combine the cervix and uterus as one CTV because I think about the movement of the cervix and uterus differently than the movement of, let's say, the parameter and the vagina versus the nodes. It is important to think about an ITV due to changes in bladder and rectal filling, as well as changes in the tumor. There's a lot of motion in the AP and superior directions. So usually you have your largest margin around your cervix and uterus. There isn't like a standard set margin to use, but you really do need to think about motion when you're doing this. The EVRT dose, I think, really should be 45 gray rather than 50. This can help reduce the risk of pelvic fractures, fatigue, GI side effects, and vaginal stenosis. When we look at constraints for IMRT, there are some suggestions here in NCCN, which I think is a very reasonable place to find guidance on kind of constraints. If we talk about like the nodes now, This is a little bit of a confusing space. So if you look in the top right, you look at the recommended total nodal doses on multiple trials, you can see that there's a range in what's being recommended. So you are rightfully so confused because there's not one answer, but the range is usually in the 55 to 60 gray range. However, you look kind of in the bottom left, there's some data, and this is one example that suggests that maybe as the nodes are larger, maybe you actually need more than that in order to get local control. And this is an evolving area. There was a recent nice paper in Pro kind of suggesting some guidelines for how to think about this. I'd say the most commonly recommended practice was to think about doing a 45 gray with a 55 gray SIB, which doesn't get you to 60. You realize that you're getting contribution from your brachytherapy to get to 60, but then maybe thinking about a sequential boost if you wanted to give a little bit more than that. The issue here is, can you give more than 2.2 per day? Like, could you give 2.3? Could you give 2.4? And I think there's some differences of opinion regarding the kind of safety of that. Again, think about the contribution of brachy to the nodal dose and your SIB dose to your brachy. This is an example here of roughly what you can expect from the contribution of the brachytherapy. For example, down in the pelvis, it's about 4 to 5 gray. So if you're giving the 25 and 2.2, that if you add that then to the 4 or 5 gray, you're getting to about 60. But as you get higher up in the commons or the periordics, you're not really getting that same contribution of brachytherapy. So something to think about. In terms of periordic nodal coverage, I think that you should cover for a positive PA node or positive common iliac node. You can consider coverage for meeting the high risk criteria as per Embrace 2. Sorry for that misspelling, which would be thinking about 3 or more positive nodes. Again, I think our standard upper border kind of right now when we're treating the periordics is kind of at the level of the left renal vessels, unless there's a node at that level, in which case you need to go a little bit higher. In the setting of not covering the periordics, usually the upper border is kind of where this intermediate risk border here is above the common iliacs. In terms of contouring, kind of what we see in terms of patterns of where nodes are, the vast majority are below the left renal vessel, which is why that upper border has been set. If you look in the middle here, most of the nodes are actually in the left para-aortic space, followed by the aortic cable space, followed by the right paracable space. Again, in that energy consensus, there are some guidelines for contouring the para-aortic region, which you can review and are very helpful, and put some of the guidance kind of here. Just trying to keep an eye on the time. In terms of if you're going to cover the periordic region, please think about the duodenum, especially if you're going to be doing an SIB. You can see that the targets here change, and so where your duodenum is at the time of SIM may not be where it is once you get 3-4 weeks into treatment. The study that's kind of cited most for duodenal constraints comes from MD Anderson, where they saw separation and toxicity according to the V55. In general, you should try to keep the duodenal dose, the V55, under 5 cc as a soft constraint and under 15 as a hard constraint. These are from NCCN. But for those of you that may also treat GI sites, you realize that there's some variation in this dose. And I think that there are some more conservative suggestions. And I would say overall, this is still an evolving area, but using the constraints in NCCN is a very reasonable, safe place to start. Okay. Brachytherapy, realize that there are a lot of changes to the tumor during external beam, and it's difficult to predict how small or how big the tumor may be at the end of brachytherapy. So you need to think about your approach from the very beginning, okay? And this is the Embrace study just showing like the variation in the treatment responses from time of EBRT to the time of brachytherapy. What are things to think about? You need to kind of think about if your standard intracavitary isodose distribution is going to fit the disease. So that can be related to size, perimetral extension, asymmetry, vaginal involvement, and organ at risk proximity. These are just examples of how different like cervix tumors look and how different kind of the rectum and bladder are. And so this is really very different for like every woman that you see. Okay. In terms of kind of how are people treating these things on the EMBRACE study, you can see that for whether it's small tumors or larger tumors, that there is an increasing number of cases that people are using hybrid applicators for. On the far right, you can see as your tumor volumes get larger in this 35 to 65 cc range, that the tandem and ovoid or tandem and ring, it's very hard to get a D90 over 85 gray, which is a goal, but as you add needles, you're able to get the dose up. So it's allowing you to get better coverage of these tumors. The hybrid applicators, what's the big advantage of them? One, they're easier to use than kind of a pure kind of interstitial template. And they're allowing you to kind of pull the dose at the level of point A about 1 to 1.5 cms laterally in an asymmetric manner. There are a lot of different options for needles, including kind of the full interstitial versus these hybrids versus freehand versus 3D. Don't have time to go into the pros and cons of each, and there are different techniques for placement, which we won't go into. The one comment I'll make on placement is to really please think about using ultrasound guidance, either transabdominal or transrectal. As you're placing your tandem, it really can significantly reduce the risk of uterine perforation. This is a summary of some target goals and organ at risk constraints. On the right, you can see the recommendations from EMBRACE 2. They're kind of pushing the dose of the D90 to about 90 gray, with a hard constraint of 85 gray. If you look at NCCN, they're kind of closer to an 80 to 85 gray, and the ASTRO consensus 85 to 90 gray, so somewhere in this range. There's also here some recommendations for the organ at risk constraints, and we're going to talk about those a little bit here. So in terms of the brachy dosing, before we get there, these are some recommendations from the ASTRO consensus. I think the most commonly used ones after 45 gray in the United States are probably 6 gray times 5 or 7 gray times 4. Also important to have a system in your clinic for summing the dose between your external beam and brachytherapy. This is kind of what we use in our clinic, which is adapted from ASTRO, where you can enter the external beam dose up here, and then the dose per fraction of each brachytherapy insertion, so that you can track kind of the tumor dose and then the OAR doses. So EMBRACE has kind of given us our guidance in terms of OAR doses, the goal to keep the rectum D2cc under 65 gray. You can see that doing that helps reduce the risk of bleeding and proctitis. In terms of kind of the bowel and sigmoid, there's still some work to be done here. On the right, you can see there's not a huge change in doses and toxicities. And so for now, the soft constraint is a D2cc under 70 gray. And the bowel probably trying to keep lower or under 60 gray. There's some correlation with kind of flatulence that you can see here. But the correlations with bowel and sigmoid have not been as clear as they have been for rectum and bladder. Bladder constraints, again, want to try to keep under at least 80 gray, and the ICRU bladder point under 75 gray, with correlations here seen with cystitis and kind of pain. The ICRU bladder point also seems to have a stronger correlation with incontinence than the bladder D2cc. It's thought that maybe that's related to it being a surrogate for the bladder trigone, and it maybe being more sensitive to radiation than the other portions of the bladder. You should try to keep that under 75 gray. In terms of the vagina, there's a lot of kind of ongoing work in this space. I think the dosimetric point that has the greatest validation is the ICRU rectal point, trying to keep that under 65 gray to reduce the late-term risk of grade 2 vaginal stenosis. There are other factors that are also associated with vaginal stenosis that are helpful to try to control, including trying to keep the vaginal surface dose under 140% if possible. EMBRACE recently has put out a few papers talking about the long-term impact of our treatment on sexual function. About half of women are not sexually active at 5 years for various reasons. About a fifth have problems with dryness, shortening, tightening, and pain with intercourse. Hormone replacement therapy is associated with less of these symptoms. And there's a little bit of a mismatch in vaginal function and sexual distress in terms of it not being like strongly correlated with our physician assessed vaginal changes. And so that's important to keep in mind. I put one example here of a question about vaginal bleeding during intercourse or other sexual activity. And you can see that over time, that this is still an issue in about 30% kind of patients. And this is like something important to normalize and discuss with women kind of long-term in terms of what they should kind of expect. What's coming next? Again, we're improving our local control. There's still a higher risk of distant failures. If we focus just on the right side here in terms of attempts to increase systemic therapy to reduce distant failures, a major trial was published kind of just recently called the Outback trial, looking at a randomization of observation versus adjuvant carbotaxol for high-risk patients that were defined by clinical features. Unfortunately, that trial was negative, so there is no routine role for adjuvant carbotaxol. The CALA trial has been presented at ASTRO, which looked at concurrent and adjuvant immunotherapy. Unfortunately, that trial was also negative. There are a couple other trials also looking at this, including the Keynote A18 trial, which is still pending but hasn't been published. Some groups are trying to move the chemo, the additional chemo up front, the Interlace trial in the neoadjuvant setting. We'll see what those outcomes are. And GY006 is currently open adding triapine, which is a ribonucleotide reductase inhibitor, and we'll see those outcomes soon. Almost done here. Is SBRT an alternative to brachytherapy boost? On the left here, we can see patients who do not receive brachytherapy as part of their overall treatment paradigm have worse overall survival. It seems pretty obvious like why that is. We talked about trying to get 85 to maybe 90 gray in between the bladder and the rectum. That is just very, very hard to do, especially with these abnormally shaped tumors without causing significant toxicities. On the right here, we can see an example of trying to do SBRT boost in place of brachytherapy. Unfortunately, this trial was stopped early due to significant toxicities. Maybe we'll reach a point where we can do this more safely. There was a phase 1 study that gave a lower dose that suggested safety, but we're waiting for some efficacy data there. I think the long and the short of it is that this is not ready for prime time, and brachytherapy boost remains a standard of care. Systemic therapy kind of at recurrence. This is just a summary of what happens to our patients if they do recur. You can see that you want to be on this curve where you kind of make it after embrace. But the 30% who recur, first line chemo standard of care now defined by Keynote 826, which includes a potentially a 4 treatment regimen: carbotaxol, pembro, and bevacizumab. But if we look at like what is the metric that they defined improvement, it was a 1-year PFS versus look at Embrace, we're talking about a 5-year DFS. So only about half of those patients will have a 1-year progression-free survival. And then second line chemotherapy now kind of includes tisotumab, which is a antibody drug conjugate against tissue factor. And you can see now, instead of a 1-year PFS, now we're talking about 6-month PFS. And unfortunately, that's only at about 30%. So obviously our goal is to try to keep these patients from recurring, because the path once they get on here is unfortunately not great. So in conclusion, we have post-op RT indicated for intermediate and high-risk features. We've seen significant improvements in local control and decreases in toxicity with image-guided adaptive brachytherapy, but we do still have work to do on OAR constraints and understanding and managing late-term morbidities. And there really are many ongoing efforts to reduce distant recurrences with hopefully improved patient selection. Oops.